We're going to move from early recognition and the non-ICU setting into what we actually do to patients with sepsis when they arrive in the ICU. And so I'm really delighted to introduce Sainath Raman, who's one of our paediatric intensivists at Queensland Children's and a clinical researcher with a focus on paediatric sepsis. Sai leads and collaborates on investigator-initiated trials that are focused on fluid resuscitation, sepsis management, and precision antimicrobial, so he fits very comfortably into this environment here. He's the co-chair of the Paediatric ICU Research Group at Queensland Kids and has secured more than $15 million in competitive research funding. Serves on the International Paediatric Surviving Sepsis Campaign Guideline Committee. So I'm delighted to introduce Sai to talk about ICU trials in children.
Thank you, Adam, for inviting me to speak today. Of course, when I'm talking about ICU trials, trials are done with a huge group of people, so I'm representing several people. So I'll start by acknowledgement of country. I would like to acknowledge the traditional owners of the lands on which we meet today and pay respects to ancestors and their descendants. So I want to go through a few trials that we have done and we are putting together in the next coming years and potentially give you a feel for where we have started and how we have come to this place. So I'll start with, they have abbreviations to make them memorable, but the first is split view. So this was a trial that we started somewhere in 2018, 2019. The focus was around whether the fluid that we give to intensive care kids makes a difference. So the type of fluid. So we have Hartmann's or plasmolite or saline that we might use. And when we started this in adults, there was a suggestion that maybe balanced solutions, so plasmolite and compound sodium lactate may be better. And so we ran a single center RCT here in QCH. And the focus was very much to run a trial which was robust in methodology and minimal in workload requirement. So for this trial, I had a $20,000 grant from QCH CERTA fund, and we were able to run a 500 patient trial on that. So that was possible only because of the data infrastructure from the team here. And with that, we were able to actually automatically extract data from our clinical information system and also report AEs and PDs. So we managed to do this in 18 months, and we were very pleased that we got to the end of the trial. The trial was with a metabolic endpoint, though, and it was, of course, single center. So it wasn't a practice-changing trial, but we had tested several of our methodologies, and we were happy that they were working. That led us to a second fluid trial, which we call REDUCE. In intensive care, when children are admitted, especially when they are critically ill, we end up giving a lot of fluid resuscitation in addition to the maintenance fluids and the drugs that they receive. And with their altered physiological state, they end up in fluid overload. And over the last decade and a half, there has been consistent observational studies that have shown fluid overload in critically ill kids is associated with morbidity as well as mortality. So moving on from a single center pilot, we then conducted a multi-center pilot here, where we created a restrictive fluid bundle, and we focused on children who were mechanically ventilated. We recruited across here, Randwick and Zurich, and we chose a very small sample size, just 154 children, but we recruited cardiac as well as non-cardiac. This would be the first or a fluid trial to include both cardiac kids as well as non-cardiac kids. We struggled with recruitment. We could only recruit 12.8% of those that we thought were eligible. But what we realized is what we thought we had good stakeholder engagement. When it came to allowing clinicians to do what they wanted, they do not follow very pragmatic trials do not allow for fidelity and protocol adherence. So that's something that we have learned from this pilot, that if you are going to run a bundle approach, especially in fluid management, you will need to be more prescriptive. Most clinicians struggle to figure out when they should de-escalate. We allowed them to start the protocol from admission to day 2. That didn't make a difference. It wasn't associated with their acuity numbers. So PLOR, which is one of the organ dysfunction scores that we look at, there was no association in that. Clinicians could not pick when we should actually de-escalate. So certainly for a fluid trial, it does not work. But what did work, though, is that we managed to recruit across 3 sites this time. We managed to recruit internationally. Professor Schloppbach helped with recruitment. We had a $50,000 budget for this. And of course, we were able to continue what we had done previously, i.e. automated extractions as well as reporting. And in this instance, we also attempted to use our registry data to an extent. So then that weaved into RESPOND, which was our multinational study, which was a pilot between Australia and New Zealand. We recruited 60 children across about 10 sites, and were able to show that we were able to recruit quite a lot of the eligible children. And we tested in RESPOND, what we tested was if vitamin C and hydrocortisone make a difference to shock resolution in pediatric septic shock. And pediatric septic shock, as the audience here will know, has a lot of management interventions that are not based on strong evidence. So we have started taking off little pieces of the evidence gap, and this is one of them. So this was a pilot, and we seemed to show that there was a shock resolution which was faster with the interventions. And so again, we were able to show multi-center, binational, successful delivery of a trial. And then we scaled up, and for the RESPOND full trial, we recruited across Australia, New Zealand, Brazil, and India from 15 sites this time. And whereas the pilot had a sample size of 60 with NHMRC CTS funding, we were able to extend to India as well as Brazil. And we completed recruitment in April this year with 400 patients, which would be the largest pediatric septic shock trial till date, testing vitamin C and steroids as opposed to standard care. But for RESPOND, we also included hydrocort as a separate arm. So this was a 3-arm trial to see if we could actually tease out whether there is a hydrocortisone effect. Adult data suggests that there is some evidence, whereas there was nothing before here that looked at that data. So we have completed the trial. We were very pleased. We collaborated with the George Institute, who have a wing in New Delhi, and the team there were amazing. So we were able to recruit and about 100 patients from India, about 250 from here, Australia, New Zealand, and the last 10 were from Brazil. We learned a lot. We had an adult large trial that showed harm in adults with septic shock with vitamin C, as we were within a year and a half of this trial. So we paused the trial. We discussed with the DSMB. We had more safety metrics included. And with the DSMB, with the trial steering committee, with the parent consumer in the TSC, we were able to progress safely. And now when we are complete, we are just writing up the paper. We are pleased with what we have achieved. So all this work, of course, led us to the next trial, which as a group, we are now fairly comfortable running clinical trials. So with Prof. Jason Roberts' group, we had this discussion whether we could bring BLING-3 to pediatrics. BLING-3 is an adult trial, 7,000 patient trial, where they looked at beta-lactam infusions as prolonged versus intermittent. In pediatrics, though, we felt just comparing it like for like, i.e. prolonged to intermittent, would be okay, but we wanted to see if it could be implemented. So this time around, we chose a hybrid effectiveness implementation trial format with Bayesian analysis incorporated within it. And with that, we have, with MRFF funding, we are just setting up to start on the lead site, which is QCH. Initially, when we started the trial design, we had a sample size of 837 with an effect size of 1 day. And since then, we have been performing simulations with the Bayesian approach. And we are using the BLING-3 data as a prior. And with that, we now actually believe we need 1,700 patients to answer our question whether continuous versus extended versus intermittent, which would be better. Again, we would be going to Europe as a hub. Zurich would be the hub, and there will be a few sites recruiting. 10 sites in Australia and New Zealand will recruit. And we've just heard from one of the initial seed grants for India. So we're hoping to recruit in India as well. So similar to Respond, we would hopefully in the next 3 to 4 years be able to deliver this trial, which will extend our traditional RCT methodology with an implementation aspect to it. And within Resonance PICU, which is a step 2 of Split B, which I started with, again, we are comparing balanced solutions to saline and critically ill children. And this time around, we are working with our registry, the intensive care registry, and we'll be doing a cluster crossover trial, again, MRFF funded, which will recruit 7,000 patients across 9 sites in Australia and New Zealand. And quite a lot of the data is going to come directly from our ANZ Pediatric Intensive Care Registry. And we're choosing a hierarchical primary outcome, and we'll also have a long-term follow-up. With this, significant burden of data entry will be limited with the registry data. And because it's going to be a cluster crossover, we are hopefully going to be able to recruit fairly quickly. We're going to, of course, randomize sites to the 3 therapies, and that would be every 2 months. This would be the first trial. We will also be attempting double blind. So the blinded solutions, we are in discussion with Baxter. We're hoping to get a blinded trial up and running, which will be the first for Australia and New Zealand pediatric intensive care. The last few slides, this all leads up to the next evolution of randomized controlled trials and addressing evidence gap. So Kristen Gibbons is a professor and who leads the group in Children's Intensive Care Research Program here in UQ, leads this work. Here, we're going to run a platform in pediatric intensive care where we will test 3 domains in the first instance. Domain 1 will be step 2 of reduce, which will be standard care to fluid sparing strategy. And then we have a ventilation domain as well as a sedation domain. We had a development grant for this, which has allowed us to create most of the paperwork required and set things in place. We're just waiting for further grant funding before we can get started on this trial. We're hoping by mid next year, we will be at a place to start recruiting. This work is going alongside Pivotal, which is in the UK, again, platform trial in pediatric intensive care. So as we work with Pivotal, it's really hand in hand, cross collaboration. Pivotal is maybe a year ahead of us. And so they've just started recruiting. They've recruited about 350 children into their trial, and they have 2 domains. So we are hoping to align our data and data CRFs so that when we come to the completion of the trial, we can do IPDMAs, which will help with the broader translation. These would be the first 2 platforms in pediatric intensive care in the world. And that's being led off here again, PQ Connect, which is a multinational network of pediatric intensive care. And Professor Gibbons is the chair. And one of the white papers that we wrote earlier was the vision was to run platform trials, and we are well on our way with those. So I think overall in the last 8-10 years now, we have finalized the methodology. We've gone from single center pilots to a full-fledged adaptive trial design. We've certainly learned along the way. We've made significant mistakes, but we've learned with each one. And the platform trials that are coming would hopefully certainly reduce the waste from research, but give answers quicker. And I want to thank the ChIRP team who have helped us get here, and all the collaborators across the countries, and Professor Gibbons and Schlockback who lead and mentor me. Thank you.
Sai, thank you so much.
Sure.
Yeah, it's just enormously impressive to see how you and the team have gone about establishing that trial infrastructure, something that I'm sure many centers around the world have tried hard to do to address the lack of data that supports the management of children with sepsis and septic shock. So I just want to, say how impressive it is again that you're going to be churning out those practice-changing data. So thanks for that. And I know that you're heading straight back to the shop floor. You ducked out of CT to present, and you're straight back to the unit. So thanks for your time.
Thank you very much. And I'm sorry, I wanted to be there in person, but I'm sorry I couldn't.